Thank you very much.
Thank you.
Take care.
Okay, thanks.
Okay, Mr. Harnoor Singh. It looks like we will have time for two additional, Mr. Singh, and then one additional, two total from the wait list, based on the hour that we had committed today. Mr. Singh, whenever you're ready.
Dear members of the Advisory Committee, my name is Harnoor Singh, and I'm a graduate student at the University of the Pacific. I've spent the last 4 years working as a research assistant at the Pacific Fatigue Laboratory and serving as a scribe at a local emergency department. Recently, Joanne, a 50-year-old small business owner, came to our research lab for a disability evaluation related to her chronic fatigue syndrome. Her long-term disability claim had been revoked. Her insurance company didn't think she was actually sick and defended their claim by stating that her physician had provided no evidence demonstrating that Joanne was prevented from maintaining a 40-hour work week. Joanne's troubles did not begin there. Prior to having her credibility questioned by her insurance company, she was dismissed by medical care professionals at her local ER. Joanne had sat in the ER waiting room for several hours before a triage nurse determined that she was indeed sick enough to be seen by a physician. She was directed to a gurney and asked to wait for the doctor. When he arrived, the physician conducted a routine history, reviewed her systems, and ordered an array of lab tests. The tests were, of course, inconclusive. You can't find what you're looking for if there isn't a test for it. The physician determined that this patient was just another pain med seeker in need of her weekend fix. Needless to say, emergency departments aren't ideal locations for the diagnosis or treatment of CFS symptoms. ER docs are trained to treat trauma and send the patient on their way, to either their homes or to admission in a different department of the hospital. As an alternative, patients with chronic fatigue syndrome are often instructed to seek the care of their symptoms by a primary care doctor, but this is also a less than ideal situation. Many primary care physicians aren't trained to consider CFS as a possible diagnosis, let alone serve as advocates for patients having trouble with ill-informed insurance companies. The traditional training that so many of our young medical students go through is failing to care for a significant number of the patient population. Physicians have become so accustomed to living in a society saturated with malingering that patients with CFS are more often than not placed in the same category. I'm concerned because as a future physician, I will also be trained in this manner. It worries me greatly that many of my future colleagues and I might not be able to care for a large group of patients due to the deficiencies in our medical education. There is hope. We can alter this vicious cycle and solve this problem. Every member of the healthcare team can be trained and educated on chronic fatigue syndrome. Adequate medical education on CFS diagnosis and treatment for all members of the healthcare team should be a primary goal, and future funding should reflect that. Medical textbooks need to incorporate CFS to the same extent as other disease processes. Residency training for young physicians should consist of rotations in various centers for excellence in CFS diagnosis and treatment. Physicians should be updated on groundbreaking treatments. These additions to medical education can and will help patients. My colleagues and I are here to ask for your leadership in support of this issue. Thank you very much for your attention.
Thank you, Mr. Singh. And if you had not submitted your written comment or your comments for the record in writing, please do so. Sometimes folks who are notified they're waitlisted hold back, but we want to be sure we've got everything captured. And those of you we are not able to get to today as well, please, you registered, you went through the process. We want to honor your interest in being heard, and please provide your written comment. Eileen Holderman, are you here, Ms. Holderman? Yes, please.
Good morning. My name is Eileen Holderman. I'm a patient advocate for ME/CFS. Today I have no formal written testimony, but I did want to make a few points. First, I'd just like to endorse the document that Dr. Friedman, Marla Silverman, and Rebecca Artman wrote for the CDC pertaining to the recommendations of the 5-year strategic research plan, and to also endorse Dr. Dharma Blashi's testimony given yesterday. I think the direction of these documents where research should go is one that is very important. Particularly, I'm talking about the need to investigate the role of viruses in ME/CFS. Basically, I just want to make 3 points. That one I just made, that we should put research into infectious agents, the role they play in this disease. Secondly, we have to change the name of this disease. There's many reasons why, but particularly I think it has come down to funding. I've said this so many times before, but if I had $1 to spend and someone said I could put it in a jar that says multiple endocrine neoplasia or chronic fatigue syndrome, I'm telling you, I'm not going to put it in chronic fatigue syndrome. It doesn't sound medical, it doesn't sound urgent, and it doesn't sound like anything that we need to fund. The name change issue is extremely important because it does correlate to funding. And the third thing I would like to speak on is the media coverage of this disease. While I was very, very pleased to hear about the news from the Whittemore Peterson Institute, the media's coverage of it really discourages me. Even the New York Times article called it chronic fatigue 3 or 4 times in the article. In my opinion, that's like taking a disease like diabetes and taking one symptom like chronic thirst and calling it chronic thirst syndrome, and then even dropping the S word and calling it chronic thirst. How's that chronic thirst coming along, you know? Or chronic coughing syndrome for tuberculosis, and then just calling it chronic cough. It is so important to convey to the public the scientific nature of this disease, because if we can get the media behind us, I think we'll start to see responsible reporting and subsequent money to research this disease. And when we talk about educating the CDC and media awareness campaigns, I think we should talk about media coaching for some of the federal health agency officials who make statements or address the press club, because there's such buzzwords out there that are so hurtful to the patient community. We can do a better job at communicating this disease with particular word choice and presenting it in a positive way and addressing it by its real name, which is ME, or chronic fatigue syndrome. So that's all I have to say today, and thank you for the opportunity to say it.
Thank you, Ms. Holderman. And with the chair's indulgence, let us go on to Mr. Oct.29, who is also here, and we appreciate your patience and sort of hanging in that balance of uncertainty. Thank you, sir.
Thank you. I'm sorry I had to leave early yesterday and missed my opportunity then. I'm an environmental health engineer and toxicologist. I'm also the founder of MCS Referral and Resources in 1994. One of the things we have researched since the founding of that organization, and Dr. Jason has also been involved in similar research, is the overlap of chronic fatigue syndrome, multiple chemical sensitivity, fibromyalgia, irritable bowel syndrome, etc. My testimony today is to urge the Secretary and Dr. Kitt, who will follow as the head of the Special Emphasis Panel, to require researchers who are presumably interested in CFS to be sure that they are actually studying CFS. We heard yesterday about the characterization of the patients in the XMRV study, and while indeed they were excellently characterized for CFS, they met both the Fukuda and the Canadian definitions. The study was unable to assess their comorbidities. We don't know what percentage also had fibromyalgia, multiple chemical sensitivity, irritable bowel syndrome, etc. We do not, most importantly, know what percentage had pure CFS without these comorbidities. And without knowing that, we can only look to the literature and assume that, like any other clinic population, the pure tails were the minority of cases that were recruited for this study. The majority of cases in any chronic fatigue syndrome clinic have one or more of these comorbidities. I'm not suggesting that researchers be told what to study, simply that whatever their study design,